Hey people, we are going to discuss the recent, that is 2019 Neet PG pattern questions for you, because this is the way you predict the future questions. So solving previous year question is one of the methodology for cracking your Neet PG examination. So you must know those things which every other aspirant is knowing, because this is a competitive exam and you cannot afford to not to know the previous year questions. In this part, it is the Neet PG recent pattern, that is the 2019 pattern questions for the ENT, and we will go into every detail that is required for you if they ask this in future, be it in any way. So which of the following is true regarding Singer's nodule? So you all know what is Singer nodule. First, we will just read the options. Laser therapy is treatment of choice, requires excision as it is potentially malignant. Most common symptom is pain. It occurs at the junction of anterior 1/3 and posterior 2/3. So basically, they are asking what is true. So the first point is you should know what the examiner is asking. They are asking what is true and not accept. So what is true according to you? What can be the answer? The answer here is very simple. It is D, that is it occurs at the junction of anterior 1/3 and posterior 2/3. Now why not A, B and C? You will get to know once I tell you something about Singer's nodule. So Singer's nodule, also called as vocal nodule or screamer's nodule, are the benign non-neoplastic growth that appears symmetrically on the free edges of the vocal cord. इसका मतलब है कि they occur on the both side of the vocal cord mostly, and they are non-neoplastic, that is benign. So it excludes the option B, which says that these are potentially malignant and requires excision. So these are potentially benign and non-neoplastic growth. Now the second thing is the excision of vocal nodule is done by phonosurgery if they are very large, but mostly the early cases of vocal nodule can be treated conservatively by educating the patient for proper use of his voice. So basically, conservative treatment is the main mode of treatment for most of the nodule, except in cases of large nodule or nodules of long standing history in cases of adults. So what surgery you do for long standing and big or large nodules? You do a microlaryngeal surgery, which is the treatment of choice, and after that you advise the patient for speech therapy and re-education in voice production. So these are the things which exclude the option B and option A. So microlaryngeal surgery is the treatment of choice and it is a benign lesion. Now most common symptom is not pain, but it is hoarseness. So there will be hoarseness of voice, and main cause is vocal abuse. So this was all about Singer's nodule. Now we will move to high tracheostomy question. Now they are asking you high tracheostomy is done in. So first we will read the options: vocal cord palsy, laryngeal carcinoma, subglottic stenosis and laryngomalacia. Now to answer this, you should know what are the different types of tracheostomy and what is particularly high tracheostomy. I will first like to tell you the answer here is laryngeal carcinoma. So I think you must be having in somewhere in mind that in cases of total laryngectomy, which is done in laryngeal carcinoma, your teacher advises you to do a high tracheostomy, because that tracheostomy or that tracheostoma will be removed with the total laryngectomy specimen. So you need to do high tracheostomy in laryngeal carcinoma, because for its treatment the patient may require total laryngectomy, and in that case that tracheostoma will be removed with the cancerous laryngectomy specimen. So this is the reason you do high tracheostomy. Now you should know what is high tracheostomy, what is mid tracheostomy and what is low tracheostomy. So a high tracheostomy is a tracheostomy which is done at the level, or you can say above the level of thyroid isthmus. Mid tracheostomy is the one which is at the level of thyroid isthmus, and low tracheostomy is the one which is below the level of thyroid isthmus. Now what is the level of thyroid isthmus? Thyroid isthmus lies against second, third and fourth tracheal rings. So that means high tracheostomy, which is above the level of thyroid isthmus, is done at the level of first tracheal ring. And what are the risk or complication? There is high risk of damage to the cricoid cartilage because it just lies above it. So you can cause a cricoid cartilage damage and causing tracheal stenosis. So the only clinical indication for high tracheostomy is carcinoma of larynx, because in such cases total larynx anyway would ultimately be removed and a fresh tracheostomy would be made in the clean area lower down. Mid tracheostomy, you do it at the level of thyroid isthmus, that is typically at the or through the second and third tracheal rings, and it is the most preferred level of tracheostomy in adults. Low tracheostomy, which is below the level of thyroid isthmus, is done generally or typically between the fourth and fifth tracheal rings, and it is not preferred. Why it is not preferred? Because the trachea at this level is very deep and is close to several large vessels like aorta and subclavian and all. So there is very high risk or high chances of complication because of its proximity to the brachiocephalic trunk, which might lead to massive hemorrhage. So this was all about the tracheostomy level and the question and the purpose of asking this question. So you know, and you can now answer in future also. So all of the statement regarding torus tubarius are true, except now this is something for answering which you should know the basic anatomy of torus tubarius. We will first read the options. Lies in the lateral wall of nasopharynx, overlies the cartilaginous opening of eustachian tube, fossa of Rosenmuller lies posterior and superior of torus, and most common site of nasopharyngeal carcinoma. Now the examiner has made it easy by asking except, because you have to just rule out the wrong statement. So can you do it? Can you do it for me? Yes, the answer is D. It is not the most common site for nasopharyngeal carcinoma, while the most common site for nasopharyngeal carcinoma is fossa of Rosenmuller and not the torus tubarius. That means A, B, C are true. Now about the torus tubarius, you already know that it is a inverted J-shaped elevation seen on the lateral wall of the nasopharynx. Now what it does, it is also known as cushion of auditory canal, as it shields the opening of eustachian tube, that is the auditory tube. Other things which you should know is that the fossa of Rosenmuller is located posterior and superior to the torus tubarius. So if you Google the image of torus tubarius, it is inverted J-shaped, and that is why behind it, that is posterior to it, is fossa of Rosenmuller, and superior to it is fossa of Rosenmuller. Another interesting point which you would note about this is two bands or two muscles arise. One is the vertical fold of mucous membrane and second is the anterior fold. One is posterior fold and one is anterior fold. The posterior fold is formed by the salpingopharyngeus muscle and the anterior fold is formed by the salpingopalatine muscle. So two muscles are there which arise from the inferior portion of the torus tubarius, and these two mucosal folds extend and descend vertically downwards. So these were the important points regarding the torus tubarius. So if you know now that A is true, B is also true and C is also true, but D was false. So it also solves, but you need to see the image of torus tubarius as I said you. Now moving to the important question like nasopharyngeal chordoma. Now this is something which most of you would confuse because this is sort of uncommon, but you have to know this because they have already asked, and if now they ask it in future exams, you would be able to answer it because you know it now. So origin of nasopharyngeal chordoma is from notochordal remnant. Now, some important points regarding this which can be asked in future, you should note it down, is that chordomas are rare malignant neoplasm arising from primitive notochordal remnants, and these tumors primarily occur in the 5th to 6th decade of life. 50% of these occur in the spheno-occipital region with the mean age of 40 to 45. So in the skull base area, they are most commonly present at the clivus. Okay, and if you see the male female ratio, they are present equally in both of them, and the usual presentation is the patient presents with headache and commonly 6th cranial nerve palsy. So presenting signs and symptoms of this chordoma includes a expanding nasopharyngeal mass along with frontal headache and some cranial nerve palsies like 6th nerve involvement and 9th and 10th nerve involvement along with some pituitary abnormality. So how you are going to treat it? The treatment is surgical resection of the tumor, and it requires post-operative radiotherapy, ideally in the form of proton beams. So a lot of important points I have told you about nasopharyngeal chordoma, and now you know so much about it, so the examiner cannot confuse you in the future exams. Now moving to the site of electrode array placement in the auditory brainstem implant. So this was one of the question which I already had discussed in my videos, and people found it and they answered it right. So I was so happy after I heard that they have answered it right. So the answer here is lateral recess of 4th ventricle. So you should know what is ABSI, that is auditory brainstem implant. So previously they were asking you about cochlear implant, and now they have proceeded to auditory brainstem implant. So these are basically surgically implanted electronic devices that stimulate the auditory pathway directly at the level of cochlear nucleus in the brainstem. So they are not stimulating the cochlear nerve as in case of cochlear implant. They are directly stimulating the brainstem at the level of cochlear nucleus. So when it is done, so the indication is when the cochlea or auditory nerve is damaged and you don't have the nerve to stimulate it, so cochlear implant cannot be done. So you have to place the electrode array in the brainstem. So this ABSI, that is auditory brainstem implant, consists of 3 components: a microphone and a sound processor, जो कि बाहर होता है, कान के ऊपर पहनते हैं, that is worn externally behind the ear to pick up sound. A decoding chip which is there below the skin to transmit the information picked by the microphone, and it is then relayed to an electrode array which is there in the surface of cochlear nucleus, that is it is inserted onto the surface of cochlear nucleus of the brainstem in the lateral recess of 4th ventricle. So why it is different from cochlear implant? First is the cochlear implant was stimulating the auditory pathway at the level of cochlea in the internal ear. ABSI is stimulating the cochlear nucleus in the brainstem directly and not in the cochlear nerve level. Another thing is the parts you already know and the placement. So cochlear implant, the electrode was being placed in the scala tympani. The electrode array in case of cochlear implant was placed in the scala tympani of the cochlea, and it is placed in the lateral recess of the 4th ventricle. Now moving to other important questions. Water's view gives best visualization of. So you see, so simple question, but most of the people, even the intelligent one, makes mistake in the exam scenario. So they may mark it as something else than maxillary sinus, because the answer here is maxillary sinus. So Water's view, maxillary sinus is the best evaluation. Basically there are 3 views for viewing the paranasal sinuses: Water's view, Caldwell's view, and submento vertex view. So there is one lateral view also, so you can say 4 views. Water's view is best for maxillary sinus, Caldwell's view is best for frontal sinus and ethmoid sinus. Submento vertex view is best for sphenoid sinus, and lateral view shows you the posterior ethmoid, frontal maxillary and sphenoid. Other thing which is needed for you is to see the diagram of each of these view, how the X-ray beam is projected from into the patient. So this can be asked in future, because they have already asked you a theoretical question. Now they can give you the image of the patient and the X-ray beam being projected. So at what angle it is projected, you need to Google it, and if you ask me, I'll post it in the comment or the community tab of the group. So do comment if you want me to post it, I'll post it there. Now the other question, a patient of acute tonsillitis present to the ENT OPD with earache. So very common presentation. Which of the following nerve is likely to be responsible for the referred otalgia? So it's basically a clinical question, and the answer here is glossopharyngeal nerve. Why I said that? Because the tonsil and the fossa are supplied by the glossopharyngeal nerve, and any irritation or pain can be referred to ear along the tympanic branch of glossopharyngeal nerve, which is, the name of the nerve is glossopharyngeal tympanic branch name is Jacobson nerve. So now you know this. Now what other referred otalgias are there? So if there is any laryngeal pathology, then the Arnold's nerve or the auricular branch of the superior laryngeal nerve can transmit this. So laryngeal pathology will be Arnold's nerve, tonsil or pharyngeal pathology will be Jacobson nerve, that is the tympanic branch of the glossopharyngeal nerve. And if there is any intraoral pathology, then the mandibular division of the trigeminal nerve, that is the auriculotemporal nerve, will relay this sensation, that is the referred otalgia. So now you know the future questions also. Arnold nerve for laryngeal pathology and auriculotemporal nerve for the intraoral pathology via mandibular division of the trigeminal nerve. So which of the following muscle is responsible for the abduction of vocal cords? Now this is something which is being asked from ages, so you know this answer. I don't think I need to tell you that the answer here is posterior cricoarytenoid, because this is the sole, this is the exclusive abductor of vocal folds in the larynx. So you cannot afford to forget, miss or mistake this, because if you mistake this answer, you are out of the game. So only abductor of larynx is posterior cricoarytenoid. Now if I ask you the future question, tell me the tensor or the relaxer of the tensor relaxer, both now the complementary action. So tell me the tensor for the larynx. So tensor, the main tensor is cricothyroid. What else can be the tensor? So tensor is only cricothyroid, but vocalis and thyroarytenoid acts as relaxer. So cricothyroid is the tensor and vocalis and thyroarytenoid are the relaxers. Now tell me the adductors. So rest of the muscle like lateral cricoarytenoid, transverse arytenoid or interarytenoid and thyroarytenoid external part is the adductors for the larynx. Now thyroarytenoid, regarding thyroarytenoid, the internal part is relaxer and the external part is the adductor. So this was all about this is all which was asked in your recent 2019 Neet PG pattern NB questions. So these are pattern because we are not allowed to make the questions out. So this I think you got it, and if it helped you, do comment how it is helping you. So this is Dr. Shivam. Stay happy and keep doing the hard work. Keep the hustle on, and you will get where you want and you will get what you deserve. Thank you and take care.